Hello, my name is Vicente Bonasser, and today I'll be presenting a systemic lupus erythematosus, also known as SLE. This presentation will focus on understanding the disease process, common clinical presentations, diagnostic criteria, and treatment options. I will also review a diagnostic and treatment flowchart that illustrates a logical approach to managing patients in SLE, and conclude with a reflection on lessons learned and challenges encountered while completing this assignment. The overview of SLE, systemic lupus erythematosus, is a chronic autoimmune disease characterized by immune system dysfunction and the production of autoantibodies. These autoantibodies lead to inflammation and damage across multiple organ systems. The disease course is typically marked by periods of remission and flares, making management complex because SLE can affect nearly any organ and is often referred to as the great imitator, which can delay diagnosis. Incidence and prevalence in the U.S. In the United States, the prevalence of ESE ranges from approximately 161 to 322 cases per 100,000 people, with an incidence of about 5.1 cases per 100,000 persons per year. Women are disproportionately affected with a ratio of about 9 to 1 compared to men. Additionally, higher prevalence and disease compared to men. Additionally, higher prevalence and disease severity are seen among Black, Hispanic, and Asian populations. These disparities highlight the importance of early recognition and culturally competent care. The typical clinical presentation. Patients with SLE often present with non-specific constitutional symptoms such as fatigue, fever, and weight loss. Musculoskeletal complaints are very common, particularly symmetric joint pain and arthritis. Cutaneous manifestations may include a malar rash, photosensitivity, and discoid lesions, while mucosal involvement may present as oral or nasal ulcers. These symptoms may appear gradually and vary greatly among individuals. The organ system involvement. In addition to mild symptoms, SLE can involve a major organ system. Renal involvement or lupus nephritis is one of the most serious complications and may present as proteinuria or abnormal urinalysis findings. Hematologic abnormalities such as anemia or thrombocytopenia are common. Cardiopulmonary manifestations may include pericarditis or pleuritis, and neurologic involvement can present as seizures or psychosis, indicating severe disease. So the diagnostic pathway. To begin with, diagnosing systemic lupus erythematosus is notoriously difficult because it is known as the great imitator. Its symptoms often overlap with many other autoimmune and infectious diseases. To bring clarity to this process, we need to follow the 2019 criteria from EULAR ACR classification criteria. So the part 1 is the clinical suspicion, the trigger. This process between clinical suspicion will look for the classic red flags, malar or butterfly rash, unexplained joint pain or swelling, sensitivity to sunlight, chronic unexplained fatigue or low-grade fevers. If these are present, we move to the official diagnostic entry gate, the part 2. is the entry gate, the ANA test. The first mandatory step in the anti-nuclear antibody, the ANA test, we require titer of higher than 1.880 on HEP2 cells. The crucial point, if the ANA is negative, we can stop right there. SLE is highly unlikely. However, if this is positive, it doesn't mean the patient has lupus yet. It simply means we're clear to look at the specific criteria. The weighted scoring system, once the entry gate is passed, will look at clinical and immunologic domains, unlike older systems. These criteria are weighted, not every symptom is equal. On the clinical side, since like class 3 or 4 lupus nephritis are heavy hitters, biopsy-proven nephritis alone give you 10 points, which is our autoimmune diagnosis. On the immunological side, we look for the highly specific markers like anti-DNA or anti-Smith antibodies. We also check the complement level C3, C4. If they are low, it indicates the immune system is actively consuming some defenses. To conclude this diagnostic pathway, to reach a definitive diagnosis, the patient must score 10 points or more with at least one clinical criterion met. This weighted system ensures we're not just reading a lab result, but a person with clear clinical manifestations of the disease. And we have, once the diagnosis is confirmed, our goal shift to management. SLE treatment is not one size fits all. We use a tiered strategy based on organ trait, essentially how much danger is the patient's vital organ function at this moment. Level 1, the universal foundation. Every single patient diagnosed with SLE starts at level 1. The cornerstone here is hydroxychloroquine, HCQ. It is no longer considered optional. It's a life insurance policy for lupus patients because it prevents flares and long-term organ damage. We also emphasize on lifestyle modifications that we'll explain later. Level 2, mild to moderate disease. If a patient has active symptoms like arthritis or skin rashes that are in control by HCQ alone, we move to level 2. Here we use a low-dose prednisone, ideally less than 7.5 milligrams a day to bridge the gap while we start steroid-sparing agents. Also, all the medications like methotrexate or azathioprine help keep the disease quiet so we can get the patient off the steroids as quickly as possible, avoiding side effects like weight gain or bone loss. Level 3, severe refractory disease. Now, if we see organ threat such as lupus nephritis, kidney inflammation, or CNS involvement, we move to level 3. This is an emergency. We use pulse IV steroids to hit the inflammation hard and fast. We introduce a heavy-duty immunosuppressants like a mycophenolate mofetil or cyclophosphamide. In recent years, biologics like belimumab or rituximab have become vital tools for patients who don't respond to traditional therapy. So we're going to explain the non-pharmacological management. The non-pharmacological management plays a crucial role in improving outcomes. Patients should be getting sun protections, as ultraviolet exposure can trigger flares, vaccinations, cardiovascular risk reduction, and routine monitoring for medication toxicity as essential. Pregnancy planning and psychosocial support are important components of comprehensive care. The reflections and lessons learned. Creating the diagnostic treatment flowchart helped solidify my understanding how complex SLE diagnosis and management can be. One key lesson learned was recognizing that SLE requires pattern recognition rather than reliance on a single lab result. The flowchart also reinforced the importance of early treatment initiation and minimizing long-term corticosteroid exposure to reduce complications. Some challenges can be Organizing the large amount of clinical and lab information to a clear logical sequence. Another challenge was differentiating between screening tests and confirmatory diagnostic. To address this challenge, they relying on evidence-based guidelines and focus on key decision points, which improve both clarity and accuracy. So in conclusion, systemic lupus erythematosus is a complex autoimmune disease requiring a structured, evidence-based approach to diagnosis and treatment. Early recognition, appropriate diagnostic evaluation, and individualized management are critical to improving patient outcomes. The use of a diagnostic and treatment flowchart enhances clinical reasoning and supports effective patient care. Thank you. These are the references that I used to support this information I presented. And thank you.